Thank you, Steve. So I see some familiar faces from the classes earlier today. Some of you are probably already tired of hearing me talk, but I hope you'll bear with me one more time. And I just want to say again what a pleasure it is to be here. It truly has been eye-opening for me to be on the Baylor campus for the first time, to see the culture and community here, and especially in the program, the Health Humanities program, which, I just have boundless admiration for Lauren for putting this together. Really, I hope you all appreciate how special this is. It truly is. I'd like to postpone my remarks on narrative for just a moment to talk about something we were discussing in the classes that I talked earlier today, and that is the idea of care, which is right there in the name, health care. And it's in light of the sense of care, I believe, that narrative centrality to health care might be more fully revealed. And by giving expression to what I mean by care here, one expression of it, I want to turn to writing from my narrative medicine work. In this case, it's a poem that was written on the inpatient service of the family medicine residency program. I used to conduct inpatient narrative medicine rounds once a week with the family medicine residents. For about 15 years I did that. They're still doing it now. It's run by somebody else who took over from me. Well, actually, somebody else who took over from somebody else who took over from me. It's been going on for quite a number of years. We have a dedicated time where we can meet with the inpatient team that's attending a physician, 2 senior residents, and the other residents, any medical students that are rotating through doing a sub-I. This poem was written by one of the sub-Is, so we read together a poem written by somebody else. I can't now remember who it was. And then I gave them a prompt. And in response to the prompt, this is what, I'll call her Janelle, names have been changed, but this is called Frigid by Janelle. My grandmother used to say, "Janelle, put your socks on first." The rim was dim, the clinking of beads, the hum of bees praying for their queen. I was 5 years old. She was still frigid. I clutched my father. "Where are her socks? Her feet are cold." Now, in this poem, which is, just a few simple lines composed in less than 5 minutes in a very busy, noisy inpatient ward, I think the student brings to our attention the basic human compulsion to respond to the suffering of others. As one of my favorite philosophers, Emmanuel Levinas, has written, the essence of ethics, the ground of ethics, lies in being called to responsibility by the other, called to the responsibility to respond to the suffering of the other. For Levinas, this philosopher, the experience of responsibility to the other's suffering is quintessentially manifest in my experience of her suffering and death. Levinas writes, "In the other's suffering, I face the inevitable and peremptory ethical problem of the medication which is my duty." I should say medication. "Wherever a moan, a cry, a groan, or a sigh happens, there is the original call for aid, for curative help. It is the original opening toward what is helpful, where the primordial, irreducible, and ethical anthropological category of the medical comes to impose itself across a demand for analgesia." Levinas declares that the doctor is an a priori principle of human mortality. The doctor is an a priori principle of human mortality. For Levinas, this is a call that is incumbent on all of us, that we feel it. We feel that sense of responsibility when we face the suffering of the other. And if you think of Janelle's poem, which we just looked at that expression of herself as a little girl, right, responding to the suffering of her grandmother, the basic demand, the call to respond to that suffering, to care for the other. In answering this call to aid, however, medicine, like all forms of conceptualization, tends to close itself off, right? Medicine's primordial imperative may be to respond to the suffering of the other, but its structure and its progression are hostile, in some senses, to that exposure to the other, driven by the need to identify everything under the category of the medical. In a sense, the call of the other is silenced under the layers of response. So all of the wonderful technology that we have, all the wonderful knowledge, the science, crucially important. Levinas would never say we should not have it. Medicine is one of the greatest creations of human beings. But there's a way in which that technology, that drive, that knowledge can become an end in itself, right? It kind of takes over as we drive toward that kind of certainty. And in a way that silences or closes us off from the call to respond to the suffering that initiated the creation of medicine in the first place. Why do we have medicine? Why are we all here? Why are we even thinking about these things, right? We're all called in some sense. We feel that call, that sense of responsibility. And in answering that call, we study, we learn, we accumulate knowledge, accumulate technology, and too often that drive toward knowing, toward mastery, becomes an end in itself, and we lose that sense of connection to the call that drove us there in the first place. And unfortunately, at times, that pervasive attitude, that mastering imperative, fosters a stance that places clinicians above or outside the stories of their patients. It reflects an all too pervasive attitude of detachment in healthcare, the ideal of a kind of objectivity, an ideal of objectivity that rests on the assumption that one must remain outside of, unaffected by the story of the other. It demands a kind of mastery or an exercise of power that becomes an end in itself. This comic kind of represents that in a certain sense, right? I didn't ask you to undress so I could examine you. I asked you to undress because it's essential to the doctor-patient relationship that I be fully clothed and you be sitting here in your underwear. To illustrate the effects of the alienation from care that can result from this mastering perspective, I'd like to offer the opening of A Burst of Light, Living with Cancer by Audre Lorde. Some of you might know Audre Lorde's work. Lorde writes about her visit to an oncologist after a large mass is discovered in the right lobe of her liver. It's a highly regarded oncologist that she's seeing, very eminent specialist, and he considers it very likely that the tumor is malignant and suggests immediate surgery. Lorde has already at this point undergone a mastectomy. She's had previous bout with cancer and treatment for breast cancer in the past. She responds to him that she just needs some time to, quote unquote, feel this thing out and see what's going on inside. She does not want to act out of panic, she explains. The oncologist, however, will brook no delay. As Lorde describes, what the doctor could have said to me that I would have heard was, you have a serious condition going on in your body, and whatever you do about it, you must not ignore it or delay deciding how you are going to deal with it, because it will not go away no matter what you think it is. Acknowledging my responsibility for my own body. Instead, what he said to me was, if you do not do exactly what I tell you to do right now without questions, you are going to die a horrible death. In exactly those words. I felt the battle lines being drawn up within my own body, right? in very vivid detail, and I highly commend this work to all of you. Lord describes the pernicious confluence of medical paternalism and bias in this painful scene. She writes, "From the moment I was ushered into the doctor's office and saw my x-rays, he proceeded to infantilize me with an obviously well-practiced technique. When I told him I was having second thoughts about a liver biopsy, he glanced at my chart. Racism and sexism joined hands across his table as he saw I taught at a university. 'Well, you look like an intelligent girl,' he said, staring at my one breast all the time he was speaking. Not to have this biopsy immediately is like sticking your head in the sand." Then he went on to say that he would not be responsible when I wound up one day screaming in agony in the corner of his office. I hope we can all see why this is a problematic form of communication, right? And it may be a somewhat extreme example, but this is from, one of our great writers and theorists writing about her actual experience, reporting what was actually said to her. Lord did end up dying from her cancer eventually, but after writing a profoundly important book about it. The alienation in the tale is acute. As clinician philosopher Edmund Pellegrino explains, a thinker that I think many of you probably already know, to care, comfort, be present, help with coping, and to alleviate pain and suffering are healing acts as well as cure. In this sense, healing can occur when the patient is dying, even when cure is impossible. Cure may be futile, but care is never futile. It was that sense of care that was denied Lord by the very physician tasked with caring for her at this very crucial time. And it can make all the difference in terms of her experience as she faces the end. The absence of such comfort and presence in this scene Lord describes is a kind of injury. It's a form of injury that she suffers in seeking help. And of course, one doesn't have to face a diagnosis of cancer oneself to feel some recognition, maybe not full understanding, but some recognition of Lord's story. One often might experience this kind of feeling of objectification, turning one's body into a thing, one's self into a thing, in entering a doctor's office or a hospital. The unusual language that's used, the objectifying language, you'll actually hear clinicians, maybe not as much as they used to, but there was a time when you would often hear somebody referred to as the knee in room 8, or the diabetic in room 3, right? Identified by their disease or their body part. One becomes a virtual body now of electronic medical records and digital scans. The scope of one's entire human experience and existence as a human being is reduced to a social history in the medical chart, just brief notes or perhaps even check boxes in the electronic medical record. There are a lot of books. You don't have to look far. Maybe perhaps you're reading some of them. Autobiographies, fiction that reflect this experience of objectification in the clinical setting, and the discontent reflected in these passages that's pervasive. And this kind of treatment, this form of treatment, of course, also has material effects on the ways and rates of recovery of patients. Clinicians also, of course, feel disempowered, diminished. There's the bureaucratic nightmares, the constraints on time that interfere with or affect the ways in which they might respond in a caring way to that intimate encounter with the patient. And there's also a lot of memoirs by physicians that reflect this. And often one will see in the arc of those memoirs that there's a shift in perspective when, guess what? They become sick, right? when they enter that healthcare system. There's dozens of memoirs by clinicians, not just doctors, but nurses and others, that reflect the arc of that story. I know that many of you are familiar with the history and part of how we got here to this kind of situation. I was talking to both classes earlier today about Flexner's famous 1910 report, which is responsible in large part for the standardization of medical education, for establishing the requirements for entry into medical education and what should be the benchmarks for achieving that mastery that is essential to good practice, and really revolutionized training in healthcare in this country, made medicine much more effective than it had ever been. It was inspired by the German system of that era that was concerned primarily with standardization and scientific rigor, all wonderful in the evolution of medicine. But even Flexner himself acknowledged that that medicine requires requisite insight and sympathy on a varied and enlarging cultural experience. And of course, as again, I know many of you know, Francis Peabody, a famous Harvard physician, as early as 1926, reminded medical students, again, it's just amazing that we have to be reminded of this, but he reminded medical students that, quote, one of the essential qualities of the clinician is interest in humanity, for the secret of the care of the patient is in caring for the patient. The secret of care of the patient is in caring for the patient. It's a profound statement from the 1920s. Well, throughout the 20th century, other critics of Flexner weighed in. Among them, for example, was Eric Cassell, who I know, again, some of you know, and some of you knew very intimately. He criticized the legacy of Cartesian mind-body dualism, treating the body as just a thing separate from the humanity of the person, and wrote, again, in 1982, that suffering is experienced by persons, not merely by bodies, and has its source in challenges that threaten the intactness of the person as a complex social and psychological entity. So, you know, really, you can see that from the very beginning there have been voices calling for these changes, calling for a recognition of the response to the humanity of patients. During the late 20th centuries, studies, including one by my CU colleague Eric Marcus, demonstrated a dramatic drop in students' levels of empathy and compassion through their medical training. That they begin at higher levels of empathy, typically, than the population at large when they start medical school, and end medical school below average on empathy scores. Such a rising tide of discontent in healthcare, my colleague Daniel Spencer has written, quote, joined with social trends and political movements of the 1960s and 70s, the civil rights movement, the growth of women's health awareness, community health centers, patient advocacy and disability rights, among many others, all combining to produce a range of innovative and interdisciplinary responses, close quote, to the need to address this disaffection and alienation pervasive in healthcare, so damaging to patient experience and to clinician experience in health. So I know that many of you are familiar with some of those responses that were developed, the biopsychosocial model, right? The patient-centered care model, relationship-centered care, all of these are actual movements that profoundly helped us to understand how we might respond. The patient's right movements, and medical humanities and literature and medicine were introduced into curricula in medical schools in the United States beginning as early as the 1970s. Your own program and our program in narrative medicine are all different responses to this call to help address this alienation in healthcare. So narrative medicine was just one among these many-pronged responses. So how did it come together? Well, in 2003, a group of scholars, clinicians, and writers joined with Dr. Rita Sharon, who, it's a name again I know that many of you know, who is an internist and also literary scholar at Columbia University. She got a grant from the National Endowment Humanities to bring together a group of thinkers from a variety of disciplines. And what we were tasked with thinking about was, how is narrative essential to healthcare? What is the role narrative plays? Narrative seems like a very important thing. I'll talk about that in a minute. So how might we understand its working in healthcare, in clinical situations? We met over 2 years, and what we did is we taught each other from our own disciplines. So I taught from philosophy. My colleague Maura Spiegel, who's a Victorianist and a film scholar, taught from her discipline. We had an author, a novelist, David Plant, a psychoanalyst, Eric Marcus, Pat Stanley, who was a patient advocate, Sayantani Dasgupta, who was a pediatrician and social theorist, and now an award-winning and very popular YA speculative fiction author. I commend her works to you if you're interested in that. Anyway, all of us were engaged already in some way in narrative studies and in the writing about and teaching humanities and medicine. In 2006, Rita Sharon published her book, Narrative Medicine, Honoring the Stories of Care. She provided a comprehensive and systematic introduction to the conceptual principles of narrative medicine. And in 2016, 7 of us collaborated on the principles and practice of narrative medicine, which really provides the authoritative, one of the places to start if you're interested in exploring this topic. Again, the principles that underlie it, the theory that undergirds what we do, and then how we bring it to life in practice. The program expanded from our initial group, and we now have a curricula across all 4 years of medical education at Columbia. We started doing workshops that we're still doing twice a year. Some of your faculty here have been to these workshops. We get between 80 and 100 people twice a year for these. We're back to doing them in person. And then in 2009, we started a master's program in narrative medicine. If any of you are curious about that, please let me know, approach me, and I'm glad to give you some more information about that. And it's expanded worldwide, narrative medicine programs. All right, so now I need to back up and say, why stories? Why this interest in stories, and why are stories important in healthcare? Well, as the great contemporary novelist Richard Powers writes, story is the mind's way of molding a seeming whole from out of the messiness of the distributed modular brain. At the same time, shared stories are the only way anyone has for escaping the straitjacket of self. Good medicine has always depended on listening to histories, so any attempt to comprehend the injured mind naturally inclines toward all the devices of classic storytelling. Only inhabiting another's story can deliver us from certainty. Just love that line. Only inhabiting another's story can deliver us from certainty. The certainty of our closed perspective, the certainty of our mastery, the certainty of all we've learned that comes too often between us and our openness and curiosity about the other. In a sense, he's describing here what's necessary for the practice of empathy, right? To escape the straitjacket of self in a in an encounter, an authentic encounter with others. In a sense, escaping the straitjacket of self could be the clarion call of narrative medicine. Stories, we contend, are the primordial means through which we make sense of and convey the meaning of our lives. Just repeat that again. Stories are the primordial, essential means through which we make sense of our lives, who we are, where we've been, how we've gotten here, where we're going, and conveying that meaning to others. And it is this that the philosopher Paul Ricoeur points to when he speaks of life as an activity and a passion in search of narrative. Life itself is an activity and a passion in search of narrative, in search of the story, putting together that story, taking up our past, bringing it into the present, and opening the future for us. Indeed, for Ricoeur, our life is the field of a constructive activity by which we attempt to discover the narrative identity which constitutes us. So for Ricoeur and others, and I would contend, our identities are narrative identities. When somebody asks you who you are, you tell them a story. Your story constantly evolves over your life. You have many stories you can tell about yourself. But that's how you convey who you are. You don't have an equation to give somebody when they ask who you are. You have a story. Your being lives in story. Medical anthropologist Arthur Frank, some of you read Arthur Frank in any of your courses, echoes Ricoeur's thought by proposing that, quote, our very selves are perpetually recreated in stories. Stories do not simply describe the self, they are the self's medium of being. It's a really strong statement, right? They don't just describe who you are as if they're external to who you are. They are the very medium of the being of the self. And one of the things that points to is the fact that we always already live in imaginative, storied worlds. Consciousness itself, your consciousness, how you see the world, how you move through the world, is shaped by the stories you've been told since your earliest childhood. The stories you heard in your faith communities, the stories you heard in your families, the stories that your cultures and communities gave you, that our nation gives you. All of these stories have shaped what you understand life to be, how you make your choices. What is a good person? How does a good person behave? What does it mean to behave badly? All of these things are shaped by the stories we've received, overlaying one and another. The primacy of narrative acts, the storied acts, the way we tell stories, to perceiving, experiencing, representing the world, interpreting the world, is acknowledged across disciplines. So there was, in a lot of disciplines, what we call the narrative turn in the last century, where there is suddenly a bursting of interest in history, psychology, social science, education, theology, philosophy, psychiatry, and literary critics, all of them coming to recognize the central role that narrative plays in our lives. Narrative hermeneuticists, so people who think about how meaning is constructed and how we interpret meaning. Jens Brockmeyer and Hanna Maratoya are two contemporary narrative hermeneuticists who've reinforced this point very strongly. And again, sorry for all the big blocks of text. You're not supposed to do that, by the way, in PowerPoint. So don't do this at home. They write, experience itself involves constant interpretation. Experience itself is always being interpreted. Our narrative self-interpretations and the cultural frameworks in which we are entangled affect how we experience things in the first place. Again, just to pause there, that we don't, they're saying, have our experience and then overlay them with the narrative frameworks. But even as we're experiencing, how I'm experiencing you in this room right now, and what I'm doing, and how you're experiencing what you're doing, is already overlaid, informed by, guided by your narrative frameworks, your frameworks for understanding. We don't have any experience that's not always already informed in that way. If cultural narratives already mediate experience as it is lived, and we keep reinterpreting our experiences as new experiences of points of view, alter and challenge our former interpretations, and new stories we encounter prompt us to refigure our narrative identities, there is no need to view narrative as a matter of imposing order from without. It's not from without, it's from within. And we're constantly finding new sources of inspiration for stories. The ways we've been telling stories might be challenged by the stories that we encounter in others and through others. They write, from the beginning, narrative is woven into the fabric of life in a variety of ways. It is not found, nor is it imposed, nor is it the result of a representation. Rather, it is created through practices of meaning construction. These narrative practices also take part in constituting our sense of who we are as individuals and as communities. And this can be for the good, of course. It is how we make meaning. It can also, we have to acknowledge, mean that we're limited by the story frameworks that we have, that we must constantly challenge what we're understanding and what we're not in the lives of others because of those frameworks, the ways we have, the forms of storytelling that we have. And even in our personal lives, when we encounter ways that we're stuck, right? We just can't move forward. We keep repeating the same behaviors over and over again, and we're desperate to find a way to move forward. Well, that involves finding new ways to tell your story, new forms of narrative construction that we might seek help in doing from others, or that we might find through our reading and our reflection. One of the things that it's essential then to understand is that a story isn't something that you can just remove the content from. Like, I'll just pull out the important data points from the story and ignore the form of the story, how the story is told, what moves are made by the story, how it's shaped, how time is constructed in the story, what are the metaphors, the structures, the genres of that storytelling. All of those things are essential to how the story constructs and conveys meaning. Again, so it's not just about, these data points, what did you remove from the story, what did you get from the story, but looking at how the story works. How are stories constructed? The reader or listener who enters the story experiences all of the elements of it, all integrated together, and none of them can be removed and still have the same story, right? So you can't say, well, retell this story, it'll be exactly the same, but I'll tell it in a very different form. It would be a different story with a different meaning. Narrative medicine is then, in a sense, medicine practiced with what we call narrative competence, which might be defined as the fundamental human skill of recognizing, absorbing, interpreting, and being moved to action by the stories of others. We use that language of competency to reflect that it's essential to competent healthcare delivery in the same way that all those other competencies in healthcare are essential to healthcare delivery. Well, how do we develop that narrative competency? Is it possible, or are we just either good interpreters or not? Our own conviction is that it is possible to really work those skills, to develop them as human beings, as human listeners, attenders. And one of those ways is through the study of literature, the development of skills of close reading, which we emphasize consistently in our work. The idea being that to listen to the stories of others with a view toward understanding how the storytellers find themselves in the situation they're in and what decisions they might make, what might help them to make, what paths we might open forward, requires the same narrative competence as reading a literary text. That the ways in which we interpret, refine our skills as good readers can also help us to become better listeners. Ricoeur and other narrative hermeneuticists have helped us to understand the crucial role that literature plays in this interpretive, world-shaping process of meaning creation. Again, Brockmeyer and Maritoya write, literary narratives have real world-creating effects involving the full realm of the imaginary and experimentation with unconventional narrative forms. Literature can question our taken-for-granted storytelling practices and open new possibilities of being, acting, experiencing, and thinking. I hope you've had, so this resonates with you in some way, that you've read a new author at some point, and after reading them, you don't see the world in the same way. They open new pathways for you, whoever that author might be, or you've seen a movie profoundly moving to you, and you step out onto the world, onto the street, and you're walking down the sidewalk, and you're still living in that imaginative world in a way that it has helped you to move through the world differently, to offer possibilities for you. They continue, narrative hermeneutics conceives of literature and the other arts as forms of cultural self-understanding that have existential relevance, exploring most fundamental issues of our existence. It examines what makes artistic forms of narrative so uniquely appropriate to expand and indeed transcend the horizon of our understanding and our imagination, to challenge us in ways that move us out of that straitjacket of self. In an interview describing how she understands her own literary efforts, Toni Morrison said, quote, "My books are about very specific circumstances, and in them are people who do very specific things. The plot, characters are part of my effort to create a language in which I can posit philosophical questions. I want the reader to ponder these questions not because I put them in an essay, but because they are part of a narrative." And philosopher George Yancey reflects on Morrison's words and writes, quote, "Morrison is not depicting abstract and universal truths, right? Not standing outside of the messy particularities of our embodied experience, but accidents of private and public history that philosophically shed light on what it means to be a self. Morrison is able to place the reader into an imaginative, and this is important, right, lived space, a powerful narrative space that is able to articulate modalities of lived experience. Hence, one might say that Morrison posits philosophical questions that are linked inextricably to narrative. After all, our lives are lived narratives, journeys of pain, endurance, contradiction, death, intersubjectivity, suffering, racism, sexism, terror, trauma, joy, and transcendence. Avoiding abstract and non-indexical discourse, Morrison reveals the power of literature to embody the flesh and blood reality of what it means to be in the world. Again, opening up a world of possible experience for us in which it's possible to live. It's not closed in on itself. When we enter literature, we're living our lives, we're still in this life, but at the same time, we enter the horizon of another world, another life, that kind of overlays the life we're living, reshaping it, altering our perceptions. each new narrative work opening new horizons. Rita Sharon writes, and this is, I promise you, one of the last of the long quotes. Not only the reading of the text, but talking about it and writing in its shadow seem to be required to achieve dividends of the learning. So reading the text, crucially important, life-altering, but there's also something else happening that when we discuss it with others, when we write about it, when we write about our own spirit experience in the shadow of that text. In the formation of the clinician, these powers of sight and meaning, achievable by the close reader and writer, are the necessary equipment for coming to envision and comprehend the meaning-making of patients, families, clinicians, and wider communities. Once they have learned to be close readers, they have the capacity to become close listeners. Once they have strengthened their skills of representation in writing, they can lend this skill to the patients for whom they care and whose accounts they may attempt to configure into a written narrative. I love this slide. Can you read it? It says, is there a doctor of literature in the house? In our field, then, we use this term, narrative competence, to make explicit the need for a kind of narrative skill. And we talk about a kind of central triumvirate, a threesome of such narrative competence with the terms attention, representation, and affiliation. These are the sort of core to that, what we call narrative competence. Attention refers to the witnessing function that is so crucial to any clinical relationship, the being in relation to the other, attending fully, honestly, and in some sense nakedly, with, as I was talking about earlier today in class, the central curiosity, the narrative curiosity to know who this is. It's a very different practice than someone who's been taught a sort of checklist of listening indicators. So in some medical schools still you'll have instruction about leaning forward a little bit, nod, make eye contact, right? Acting as if you're paying attention, right? That's very different than actually coming into someone else's approach. And you can tell, can't you, when somebody's really listening, and when they are, and when you're listening, the energy that you feel between you is palpable. To illustrate this practice of attention, I'd like to read a story. This was written by one of the residents in family medicine that I worked with. And I did a workshop with them every year, a 3-day workshop, and as part of that practice, I would have them write to a prompt. The prompt was, write about a time you were moved by someone's suffering. It wasn't even necessarily patient suffering, but I opened it up for them to just look at what it means in that regard. And this was not written in 5 minutes, as many of our prompts are. This was a sort of day-long exercise, and they were able to go off and spend some time reflecting and writing. But I want to read it because I think it conveys what I want to say about a quality of attention that this resident shows in this patient encounter. In the callous jargon of our world, I inherited her from the ICU. She was just another task for me to accomplish before I would go home that night. Her name was Lillian. She had quite a string of misfortunes leading her into my care. There she lay with a tube in her mouth to help her breathe, her poor limbs swollen, reminiscent of rising dough because her body had become unable to regulate its own fluid. All of this because of an infection on her foot which had gone unnoticed until it was too late. Seeing her for the first time, I was moved to wonder about the type of woman she was when she had known what it was to be healthy, happy, and strong. Despite the noise of the ventilation, which rhythmically hypnotized you into a combination of humility and gratitude for your own health, she appeared to be a woman who enjoyed being pampered Her hair was white, well cut, and well moisturized. Her toenails groomed and colored in a shade of rosy pink. Her skin had the appearance of having had regular facials at one point. Every day a new facet of who she might have been revealed for speculation. The first few days I would greet her, speaking loudly to be heard over the ventilator. On good days, she would follow me with her eyes. It was her eyes that stunned me into accepting her as a real person. I couldn't carry on a true conversation with her. She couldn't speak with the tube in her mouth. But then one day I had to examine her. When I leaned over her motionless body, she looked at me. It wasn't a blank stare. It wasn't a look of desperation. Just a simple look that said, "See me. I am somebody." I started to have conversations with her after that, fill her in on current events while drawing blood, tell her what a charming family she had visiting her. As for her part of the conversation, I would just let my imagination wander. Lillian was preparing me for her departure, though I didn't recognize it at the time. She lost the sparkle in her eyes. She was slowly letting go, and just when I was starting to get to know her. Each day was more difficult than the one before because now I searched for that sparkle, and it never returned. No amount of medical voodoo would make her change her mind. 2 days before she left, I stopped by to talk to her. Something was wrong. All of our numbers showed that she was holding on, but she had tears in her eyes. What was she trying to say then? I touched her swollen hand and said, "It's okay, Lillian." She decided to leave when no one was looking. So I just think that story encapsulates so beautifully the moves that this caring resident makes in connecting with this patient and attending to this patient and using her imagination and having conversation, filling in the other half of the conversation that couldn't be had, right? She doesn't know what Lillian would have said, but exercising that imagination allowed her to reach out, to stand in a caring relationship with her. And look at the attention to the clues that she finds, just physically in her, the way that her body was cared for, that allowed her to know certain things about her as a human being, as a person, not just as a body lying still on the bed. The second narrative competency is representation, representing our experience. It's related to the first. Representation refers not only to a clinician's need or our need in life to communicate the patient's story in the form of a chart note or a letter or a phone call referring to another physician, but also anterior to that, the need to represent the patient's story to herself through her imaginative and storytelling processes, as you just saw in the case of the resident caring for Lillian. Asking questions like, what is this I have just witnessed? What does it mean? Remember the point I touched on earlier about not knowing what you've experienced until you tell the story, right? So understanding the meaning of these events requires representing them to yourself. In some sense, some philosophers will insist, and hermeneuticists, that we don't even have experience until we've represented it to ourselves. We might have undergone something, even undergone something important, but to have an experience is to represent it to ourselves, to reflect, to bring it into language, to bring it into some kind of representation, language or some other form of representation. By writing about a patient, sharing the written text, and allowing for responses and discussion, a number of purposes are served, we propose, that assist caregivers in contending with the tasks they routinely perform. So we will often in narrative medicine find that writing, constructing a poem, as that medical student did that we started the work with, a short narrative, can give shape to experience, providing the writer access to experiences that without that self-imposed form could prove potentially overwhelming. So coming back to that earlier point about how do we remain objective? How do we undergo these experiences? And all of us undergo experiences of suffering in our lives, sufferings of others who are close to us, and certainly clinicians undergoing the suffering of patients, the deaths of patients, without simply saying, okay, I'm just going to not allow that to affect me, right? Impossible. We're human beings. How do we move through that without putting up those barriers? And this isn't about writing a long story every time you've had an experience, but taking the time when one has had a powerful experience to reflect on its meaning, to give it a place, a container, right, a form that can help us make sense of it so that we might then be able to encounter the next person suffering. It's a meaning-making process in which witnesses, or those who intend, must engage. So I'd like to bring this to life with another story of an actual experience, and this is again with another of our wonderful family medicine residents at Columbia as part of that workshop I was talking about earlier. And in this case, we had read Raymond Carver's story, A Small Good Thing. We did some really intense work, close reading that story, and the interns engaged in a rich, detailed discussion of all the aspects of the story that we've talked about earlier. And then I asked them to write to that same prompt, write about a time you were moved by someone's suffering, and the story itself has at its core a character suffering. And so again, another story about a patient death, because that's often where clinicians will go when they're writing about experiences they've had, profound experiences, because that's where we really come up against our limits, right? The thing that challenges us the most. So they came back together, and when they came back, I'll call this resident Helen again. The name and some of the details have been changed. She volunteered to go first, and before she read, she said, I know everyone else's is going to be better than mine, so I'm going to go first. Well, you'll see by the story. And I also just want to say that before she read, she said, you know, this patient came on the wards, another alcoholic, right? And the team, at the time, you'll often hear this kind of language used, unfortunately, I think still in inpatient settings, like, waste of space, this guy brought it on himself, here he is, you know, we've got other patients very sick on the ward who have illnesses that aren't self-inflicted, right? And this is after, of course, having already been instructed about the pathophysiology of alcoholism, that alcoholism as a disease, and yet, right, the attitude persists. So here is what Helen read. Caldwell was dead. When I see a freshly dead person, it always amazes me how close anyone is to being dead at any given time. Even as we walk around our homes, the streets, or the halls of the hospital, people are much closer to being dead than they imagine. Death is what we're so afraid of, and what we as doctors struggle valiantly against. Yet time and again, I'm surprised at how relieved I am when it happens. Even though Caldwell was a young man, he seemed so much better off. He would no longer have to suffer the indignities of pre-rounding, my racing into his room at 6 a.m. and assaulting him with rushed yes or no questions as he struggled to be understood and was not. He would no longer have to brook the painful prodding as I attempt to quantitate his scrotal edema. He would no longer have to endure the ridiculous hope. Surely he sensed that he was some kind of failing scientific experiment. That's how medicine is different from, say, an accident. In death by medicine, even as the intensity of a patient's suffering while alive is brought into excruciating clarity by the peace of their death, there is relief. Caldwell's ex-wife was in the room when we arrived to pull his central line and to perform the perfunctory assessment of his deadness. It appeared that she had found the love for him that she had lost for so long. Dead, he was no longer the weak, obnoxious, self-destructive, lying, smelly bastard drunk that had ripped her life apart. For so many years, she had hated him. Not only had she wanted to see him dead, she had wanted to kill him, mostly because she blamed him for the fact that she no longer loved him. Now, with Harry dead, she showed me a picture of the two of them together at a friend's wedding long ago. He was so beautiful. Poor baby, she said, as the tears flowed down her face. She hugged and kissed the swollen yellow corpse that streaked of Desitin cream. His face so little resembled the face in the photo. I felt most sorry for Caldwell, not because of the alcoholism, the cirrhosis, the hepatorenal syndrome, the failed peritoneal taps, but because she required him to die before she could show him how much she loved him. Now I want to do a little bit of close reading of this, one aspect of this story, and that is if you look at the remarkable temporal configuration, how time is constructed in the story, and how central that is to the meaning conveyed in this story. You know, she could have told the story strictly chronologically, right? If she told it chronologically, it would have begun with Caldwell's life when he is a young man and progressed to the progression of his illness as she came to know it through the wife, progressed through his hospital stay and all that happened there, and then ended in his death. But she begins, doesn't she, with his death. Caldwell was dead. That's, in a sense, the present of the story, right? The story is set right after his death. That's the present past, if you will, of the story. She moves from that past to the immediate, to the present tense that describes a recurring event, right? So Caldwell was dead at that moment, immediately after he died, to this reflection on what it means when she sees a freshly dead person generally. So she steps out of the story to offer this kind of reflection on what happens recurringly in her life. From there, she returns to that past tense, right? So everything in yellow is progressing from that moment of just after he died. Even though Caldwell was a young man, he seemed so much better off. He would no longer, right? All these things are true of what's happening now that he has already died. So she continues to talk about what that meant, what he would no longer have to because he's already died. Then she flashes back, if you will, to a deeper past. Surely he sensed when he was still alive, right? So we're no longer in that past after his death, that he was some kind of failing scientific experiment while he was in the hospital, immediately before his death. She then flashes forward again to continue the story of what happened after his death. His ex-wife was in the room when they pulled the line. It appeared that she had found the love for him that she had lost for so long. So she's come back and sort of narrated forward a little more. But then she goes back again to that deeper past, what happened for so many years before he died. All those years when she hated him, when she, because of his illness, and blaming him for the fact that she no longer loved him. Then she returns to that narration of that continuing present, right? See how it's going back and forth, bringing these temporal times together. In the way that she's doing this is the way that she's constructing meaning of the event. Now with Harry dead, she showed me the picture. And then she flashes way back to the deepest past, when he was so beautiful, long before his illness had progressed to that point, long before he was in the hospital, even before she had grown to hate him, right? The deepest past is in that photo, nested there in the story. She returns to the present again to continue that narration after going all the way to that deep past. Poor baby, she said, as the tears flowed down his face. And then she comes back to see again at the beginning, it's in green, because like at the green moment, it's a general reflection, what she's in a sense taken from the story. And the fact that she required him, his wife, to die before she could show him how much she loved him is why she feels most sorry for him. So what is the decisive event in this story? Well, it's that picture, right, from the deepest past that moves her to recognize that this man was a beautiful young man, full of potential in life, loved by his wife. And that picture, in a sense, then becomes a metaphor. And you know how metaphors collect meaning, right? They bring us into, they condense and distill meaning for us. So the photograph, in a sense, becomes a metaphor for the devastations of his disease. Who would choose to go from that to the state that he was in when he was entered into the hospital? What Helen reported after reading to the group, and so she read this to the group and we reflected back, and I actually did a kind of temporal analysis of it on the chalkboard with the group. What she reported was that she would never see a patient with alcoholism in the same way again. And 10 years after she wrote this story, I contacted her. She's now a physician in practice for many years, to ask her for permission to use the story in a publication. And she said, absolutely. And she said, you know, I've never forgotten that photo. And she said, I have never treated or seen an alcoholic patient in the same way since. So what's the difference between this and having listened to lecture after lecture about the disease process, right? There's something about engaging in this, and it wasn't just enough to have had the experience, but to write about it, to narrate it, share it with others, have its meaning reflected back to her, that makes the process even different than just writing in a diary for oneself. Writing and sharing the story offered Helen a means of memorializing or placing the meaning of this event, radically dislocated by her professional training. This gives her resources, I contend, with which to be more attentive the next time she faces someone like Caldwell. So you can see attention and representation are interrelated and can be healing. A healing that's crucial if we're, after experiencing traumatic events, able to move on without building walls between ourselves and others. Moving beyond those walls, of course, is exactly what affiliation means. Affiliation between clinician and patient, clinician and family, clinician, and ourselves, right? Affiliating, in a sense, with ourselves. Understanding our experience, being kind to ourselves. Sharing of stories requires and creates a narrative community. You see this time and again. I know some of you are engaged in a writing course right now that Steve was talking about a minute ago. And I know that process must be forming you in relations, a community of storytellers sharing with others. There's nothing like it, like the intimacy, profound intimacy that comes from the sharing of stories. So we teach also that ethics, that narrative medicine has a responsibility to move toward social justice. So remember I talked earlier about the ways in which we need to escape that straitjacket of self to attend to others, and the centrality of narrative resources for doing that. Proposing that works of literature, quote, allow a reader to perceive the way race, ethnicity, gender, and sexuality actually matter, both in the sense of being important and meaningful, in the sense of becoming materialized in individual lives. Literary scholar Paula Moya argues that literature enables an author and a reader to engage dialogically at a deep emotional and epistemic level with the difficult questions around race, culture, and inequality that are inevitably raised by a good multicultural work of literature. Such dialogic interaction can, I suggest, prompt a reader to question and then revise some of her assumptions about structures of racial and economic inequality and how they are sustained. And while questioning does not ipso facto lead to epistemic and emotional growth, the former is at least a precondition of the latter, close quote. So moving us out of those straitjackets of self that condition how we understand others and ourselves. I know I'm coming up on oh my gosh, I'm past time. How did that happen? I'm so sorry. I'm going to give Recur the last word. I'm going to flip past. I don't know how I thought I would have time for also doing exercise, but I'm going to allow Recur to have the last word again. Recur writes that we tell stories because in the last analysis, human lives need and merit being narrated. This remark takes on its full force when we refer to the necessity to save the history of the defeated and lost. The whole history of suffering calls for narrative. Thank you all for your attention, and again, I'm so sorry I've gone over. I've got one more slide. Oh, one more slide. Oh, good news. The results show it's a metaphor. Thank you all.